Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. Today on the podcast, we have Michael Chernew to talk about a new ahead of print article from CMS's Office of the Actuary to discuss National Health Expenditure Projections 2023 to 2032. A lot to talk about. Michael Chernew, welcome to the program.
Jeff, thank you so much for having me. This is an important topic. And just to clarify for the listeners, I'm going to be speaking today in my role as a Harvard professor as opposed to any other roles I might have.
Fantastic. Thanks for that up front. And so, Michael, can you tell me when you read the paper, what were the top line findings?
Well, I think when a version of this paper comes out every year as they update their projections. And I think everybody looks to see what the projections are for the share of GDP being devoted to healthcare. This year, it is 19.6% by 2032. And I think that's really the top line number that people look at. And then there's a lot of detail underneath that.
And so the 20% projection by 2032, that really spoke out to me. For someone that's not steeped in health policy, can you maybe explain the implications of this?
Sure. I think it's important to understand that there's different segments of the healthcare marketplace. Medicare, Medicaid, those are the two largest public healthcare segments. And then commercial is the largest non-public sector spending. And the implications are a little bit different. On the public side, I think the biggest implication really relates to taxes. We think we're talking about healthcare, and we largely are. But when people read this, I think they're really trying to figure out what is the fiscal burden of the healthcare system going to place on federal and local governments. And I think that matters. On the private side, I think it's important to understand that if healthcare spending continues to grow and grow rapidly, employers in particular who provide most of the commercial coverage are looking for ways to slow that spending growth, and those ways may influence their employees and the other dependents. So, for example, the generosity of coverage is likely to deteriorate more when healthcare spending is rising more rapidly, or employees or their dependents will face other restrictions, maybe narrower networks, for example, as employers struggle to find ways to manage healthcare spending growth.
Yeah, one of the numbers that struck out to me was by 2032, about 10% of the spending projections will be attributed to out-of-pocket cost. That is not that expensive now, but it just struck me how much that's going to change.
And that's after there's been a lot of protections in some of the public programs. So yes.
Yeah. Well, speaking of the public programs, there's a lot of information here in the paper, which I encourage listeners to check out. We're not going to go over everything in the paper, but there's a lot of information about how Medicaid and Medicare breaks out when it comes to health spending projections through this time period. Maybe we can go into Medicare and Medicaid one by one if you're able to talk about that. But there are some near-term projections and then farther-term projections. So with the Medicare near and far-term projections, what struck out to you?
I think the key thing to understand in Medicare, near or far, and again, I would put less stock in the near-term projections, in part because some of the growth rates reflect some of the changes related to the public health emergency expiring and a bunch of other things related to that. But I think the core point is a lot of folks focus on prices in the American healthcare system, as they should. There's a famous paper, it's The Price is Stupid. And again, I think that's important. But in the Medicare space, the projected spending growth is largely a function of growth in the number of beneficiaries as the baby boomers move into the program, and assumed growth in utilization. And one of the core things across all of these sectors is that the actuaries have to make assumptions about utilization growth, and that return to sort of a trajectory in utilization growth drives a lot of spending growth. But in Medicare in particular, prices are not the big issue. Price growth in Medicare, actually, if you look at other reports from the Office of the Actuaries, suggests that it's actually going to be below inflation. There's a lot in the current system that tries to dampen price growth paid in the public sector. And so the Medicare problem is, by and large, not a price problem. It, by and large, is a demographic problem, which isn't bad per se, and a utilization problem, which is more complicated to assess.
Yeah, so I'm glad you brought up the It's the Price is Stupid paper. That's was published by Health Affairs in 2003. And will also give me a chance to stump. Do you want a shirt of this with this saying on it? Let us know, communications@healthaffairs.org. Just an idea we've been cooking up. Not sure if it would actually happen, but just curious on that. Back to the utilization thing that you bring up. So, one of the things that we've been hearing a lot is the silver tsunami, the aging of the population, however you want to call it. How might that affect the Medicare utilization that you're related to?
A lot of the part that's due to aging is captured in the aging part. The utilization that we're really talking about now is once you've adjusted for age and demographics more broadly. And so the utilization rises with age, but the utilization factor that people are talking about is typically once you adjust for age, there's still an increase in utilization. New medical services, some of them are new drugs. So that's the type of utilization I think that people are concerned about.
Right, that's fair. Just because you age doesn't mean you will actually use certain healthcare services.
Yeah, and the extent that you do that gets captured in the aging bucket, not in the utilization bucket.
Right, right. Well, thank you for that. Thank you for that. Moving on to Medicaid, what can you tell us that struck out to you with that?
Medicaid is a complicated program because there's a lot of different programs and because the interplay between Medicaid and commercial and particularly the exchanges is important. And there's been a lot of, though in the near term, you mentioned there are differences. And some of that's just because of what's happened due to COVID and the things people, the rules for qualifying for Medicaid. And now there's this process of redeterminations for putting people onto the exchange and things like that. But I think the big issue in Medicaid, again, is going to be what happens with eligibility and the number of people that are on Medicaid. And remember, Medicaid covers not just people under 65, but a lot of the Medicaid spending is for people in long-term care settings. And so I think there's a lot there that we need to pay attention to and think about. But I think a lot of the trends are going to have to do with how Medicaid eligibility changes and how that interacts with other parts of the system.
Yeah, one of the things that struck out to me was that the projected peak of Medicaid enrollment was 2023. Just something to note. I thought that was interesting.
Yeah, and again, that's in part because of the way the COVID rules were played out.
So, as a policy wonk, what are the more immediate trends that health policy wonks and insurance experts should pick up on from this paper?
Again, there's a lot of things that I think are important. I'm going to raise a few, and I'm sure others would pick their own. I think the interplay between Medicaid and private coverage is important, particularly with the exchanges. I think the assumptions regarding the IRA and drug prices is going to end up being really important. We're at the beginning of the implementation of the Inflation Reduction Act, and there's a lot of things that it did related to coverage and in particular prescription drug markets. We haven't talked a lot about Medicare Advantage, but Medicare Advantage and the growth in Medicare Advantage is central to what's happening in the Medicare program. I think that's worth some attention. And although they don't really emphasize this a lot, I should say that these projections are really done in what's called a current law framework. In other words, the Office of the Actuary assumes the current law stays in force. And in the public sector, Medicare in particular, current law calls for a very slow growth in fees for, say, physicians and hospitals for a range of reasons. And I think we need to pay attention to that. If you were to look at the trustees report for the Office of the Actuary, for example, you would see they have a baseline projection, which is under current law, but they also have an alternative projection where they really allow certain things in current law that they think might be changed to be relaxed. And I think we need to pay attention to that when we look at these and remember that these are not forecasts of what will happen. They're forecasts of what will happen if there's no changes in public policy or laws. And I think it's likely over the next 10 years there will be.
That's a safe bet, I would say. You mentioned that the drug spending and price factors could be complex with the IRA. I know drugs aren't drug pricing isn't your typical forte, but is there anything that you want to comment on when it comes to like the drug spending? I noticed had a big increase for the projections, but would go down to based on IRA policies.
Yeah. So, I think the two big things have to do with the benefit design. So there was coverage redesign that's going into place. There's out-of-pocket max. There's a bunch of other things that protect consumers. So some money's getting shifted from out-of-pocket to the government and to drug companies for that matter. And then, of course, there's the drug price negotiation, which I think is what most people think of when they think of the Inflation Reduction Act. One of the core issues is going to be how that influences innovation in medications and which drugs we're getting. You've heard people on both sides of this debate arguing what the effects will be. I'm not going to take a side in that debate. I will say I've seen some articles about current, IPOs in the drug space, and it doesn't seem like we're right now facing calamity. But I do think it is worth watching because this is actually potentially a very significant change in the way in which drugs are priced, which will work all the way through the system. But right now, I don't see evidence that we've seen an immediately drying up of capital moving into the drug space.
Okay, we have about 3.5 minutes left with this. So overall, what do these projections tell you about coverage and cost in the United States?
Well, that's a long and complicated question. I will say coverage isn't complete, but if you look at what they have, we're basically at record coverage right now, around 93%. So we've done a reasonably good job of making sure that Americans have health insurance coverage. We have to worry about whether that coverage is sufficient, but the simple checkbox of do you have some insurance coverage, we are performing relatively well, at least by American standards. And of course, costs are still an issue. That's the message that comes out throughout this entire paper. And I should add, and I think this is important, rising spending isn't necessarily a bad thing. If we're spending more because we have older people, it's not a mystery that healthcare spending is going to rise. I think the core message that I take from this is we need to find ways to deliver care more efficiently, to make sure that markets work better, to address prices, particularly in the commercial sector, to address low value care. Spending is utilization times price. So we either have to make the pricing system work better or we have to manage utilization. And I think there's a bunch of other things we really need to focus on. Administrative costs, particularly those that are driven by oddities of our system, I think are a big deal. I think the fact that we see this return, in fact, they use this in the paper, this phrase return to sort of historic trends in prices and utilization, means that we need to figure out how we are going to manage historic trends of prices and utilization. I'm not sure historic trends of prices and utilization is a policy outcome we should aspire to, but we do need to make sure that people have access to high quality care. And so the more we can identify efficient ways to deliver care, perhaps new technologies, ways to eliminate low value care, ways to design the system so we'll have less administrative spending, ways to avoid rent-seeking behavior by producers of care. There's a lot of attention now to private equity in this space, which oddly can both provide great innovation and exploit the system in deleterious ways, is where I think we're really going to need to focus, because as we approach 20% of GDP devoted to healthcare, future growth becomes even more burdensome. So a gap between income growth and healthcare spending growth is, an issue when you're at 5% base, but when you're at 20 or 25% base, that gap is much bigger mathematically. And so I really think we are going to be entering a decade and maybe multiple decades where the concern about how to manage spending comes to fore, making sure that we can do that without having deleterious health consequences.
With that, so it seems like this paper, from the way that you're answering, is somewhat exciting. So, is that correct? Is this an exciting time for a health economist looking into these projections?
I've been doing this for a long time. You can't see me on the podcast. I don't think there's ever been an unexciting time, which is probably bad news for the American healthcare system, honestly, at least from the point of view of an economist. There has, been continual concern about spending and coverage and quality and prices. And I'm not sure I would call these results exciting, but they do mean that we have a lot of issues that we need to continue to address so we can hopefully end up with an outcome that might be a little more fiscally favorable than the projections currently suggest, acknowledging that there might be some places where we're going to need to put some more money in. So we need to make sure that we can get rid of as much as we can any inefficiencies that exist in the system, and they do.
Fantastic. Michael Chernew, thanks for joining us on Health Affairs this week. Final question, anything that you want to point our listeners to that you have coming up?
I don't have a great set of things that they should look at. I think that the listeners, by and large, should continue to track the things that I imagine they are tracking, which is what's happening in the Medicare space, what's happening in the Medicaid space, what's happening in commercial sector, particularly around prices and consolidation. And hopefully I can come back and join you again and we can discuss whatever we have learned about those things.
Well, fantastic. Again, Michael Chernew, thanks for joining us on Health Affairs This Week. Thanks to you, the listener, for listening. Please send this to the health economist in your life. If you are not sure if someone is a health economist in your life, feel free to send this episode to them anyways. Thanks and have a great day.
Thanks, Jeff.